Hello, everybody. My name is Larry Hofheimer, and I am the founder and chairman of the Macular Degeneration Association. As you could see from the opening slide and the invitation to this event, our organization is focused on educating the general population, and particularly patients with eye diseases, focusing upon other things on macular degeneration. I'd like to thank our sponsors that help support these virtual programs, including Regeneron Pharmaceuticals, Novartis, and Notal Vision. The Macular Degeneration Association is proud to be able to educate as many people as possible during this time of pandemic and need to do virtual programming. We have for the past 10 years conducted programs all over the country with physical space in hotels primarily. We will probably resume doing that again either late this year or early 2022. So all that, I welcome you, and I also urge you to go to our website, which is macularhope.org, to see the future programs that we'll be doing for the rest of this year. So we've got some very interesting subjects to talk about. Also, there's a survey available at the close of the program. We would take you about 3 minutes to complete. We would appreciate if you would do that to help us improve our programs. I now am pleased to present a very interesting speaker. Her name is Duanes Niebuhr. Dr. Niebuhr is an optometrist who provides comprehensive family eye care and specializes in the management of ocular diseases and pediatrics, in addition to prescribing contact lenses and glasses. She provides care for patients of all age groups, including children, and often treats eye infections and trauma, in addition to prescribing contact lenses and glasses. A board-certified optometrist, Dr. Niebuhr received her optometric degree from Illinois College of Optometry, where she was a member of the Gold Key National Honor Society. She completed her residency at Kansas City Veterans Hospital in 2007. She earned her undergraduate degree from Kansas State University. It's now my pleasure to introduce to you Dr. Niebuhr, who will be talking about eye conditions, double vision, etc. Dr. Niebuhr, my pleasure to introduce you.
Thank you. Hi there. Hi, everyone. Thank you so much for having me. I'm going to go ahead and start sharing my screen here. Well, thanks again. Thank you so much for having me. I'm going to be discussing double vision today. This is something that has certainly affected myself. It's affected my family, and it certainly has affected my patients. So I'm excited to kind of teach you guys some things and answer questions and just give you guys some case examples here at the end so you can kind of get a better understanding of double vision. So let's just start off with causes. So we're going to kind of talk about double vision and what it is. So double vision occurs when a person sees two images and there really is only one. So just as in this photo, as you're looking at it, it can kind of get confusing for your brain. You're seeing two different things, but they're sort of overlapping. And this can definitely create issues with patients as far as with balance. Often I have patients who have double vision who have difficulty going up steps or curbs. I have patients that complain about movement problems, especially when driving. I hear that all the time. Patients complain of they're driving down the road and all of a sudden they see two lines, and it can often be very scary for patients. And definitely I'd say my most common one is with reading. Patients are trying to read something and they're going along and they can't find the next line, or they see two lines. And this can all be very, very unsettling for patients. And so it's great to kind of understand how it works and how we can help them and fix the double vision for them. So there's three main causes of double vision, and we're going to go through those pretty extensively as we go throughout this. But the first one is a nerve or muscle damage. So there's something that's happened to that eye muscle that causes it not to work properly. Trauma, any kind of accident to that eye muscle can definitely cause the muscle to not work and can cause double vision. And then we're going to talk about different medical conditions, such as diabetes and high blood pressure, that can cause weakness to these muscles and not allow them to work properly. So we're going to kind of just teach you a little bit about the muscles, where they are, and kind of go through that, and then we'll discuss what causes the double vision exactly. So if you guys can look at this photo, I'm going to show you all the different muscles of the eye. And don't worry, there's not a quiz on this. It's just something to kind of, I'm a visual learner. So the first one we're talking about here is the superior rectus muscle. And this is the muscle that attaches to the top of the eye. This is the muscle that allows the eye to look up. So if something happens to this muscle, if there's blood supply not getting to the muscle, or there's trauma to this muscle, the eye would not be able to look up. In contrast, down here is the inferior rectus muscle. This muscle allows you to look down. If this muscle isn't working, you're not going to be able to look down. So one eye might be looking straight ahead. The other muscle would not be looking in the same direction, causing the double vision. Over here on this other side is the medial rectus muscle. It's kind of hidden behind this one, but that is the muscle that allows you to look in or towards your nose. Something happens to that, you wouldn't be able to look in. Then we have the inferior oblique here, right here. And this muscle does two important things. It actually allows you to look up, and it kind of rotates the eye. So it kind of turns the eye as well. So if that muscle is affected, it could certainly cause two different issues as far as where your vision is looking. This muscle up here, the very top one, is called the levator muscle, and that actually attaches to the eyelid, and it causes the eyelid, if it's not working properly, your eyelid will become droopy and it will start to kind of cover the eye. And that can actually affect both the eye muscles. If there's something here, such as a tumor or something pressing on the eye, it could actually affect the eyelid or the eye muscle both. So that's the levator. The superior oblique, one of my favorite muscles, and one I see often patients have problems with this one, is because of this special little area right here. It's got a tendon here that it attaches to. And this one actually allows you to look down, and it actually inverts the eye this way too. So this little pulley system often gets stuck and that muscle is not working. And so we often see lots of problems with the superior oblique muscle. The last one is the lateral rectus muscle. This is the largest muscle here, and it's on the outside of the eye. And that's the muscle that allows you to look out. So often I see issues with patients complaining about that muscle when driving. If there's not getting the innervation to that, they cannot look out and they cannot see to where they're going for driving. So that's just a quick review of the eye muscles. And then now I kind of want to talk about something called strabismus. And if you look at my little picture over here, you can see that his muscles, one of them is straight ahead and the other one is turned out. So it's a misalignment of the eyes, or one eye is turning out. So the eyes are definitely not focused together. So one eye is seeing an image straight ahead, one eye is seeing it out. And so you're seeing double vision. Now this can be constant, as in the case for him, it's constantly going out, or it can be intermittent. It can happen, when you're tired, or if you're sick. Sometimes we see patients, their eye will start to turn only when they get tired. I'm going to talk about different types of muscles and the way they move, and we'll kind of go through those now. This is what we call ESOtropia. And this is what actually both of my kids and myself have. And this is where the muscle goes in like this. It's called an ESOtropia, an eye muscle turn. Now, for me and my daughter, when we wear our glasses or our correction, our eye will stay straight. But if we didn't have our glasses on, then the muscle would turn in and cause an ESOtropia. All right. The next one is an EXOtropia. That is an outward moving of the eye. And as you can see in this little girl, her right eye is turning out. So this one is straight ahead, and then the right eye is moved out. So it's an EXOtropia. HYPERtropia. As you can see, this is very evident in her left eye. This muscle is up. The right eye is looking straight ahead, the left eye is up. So she's going to be seeing two images unless for some reason her brain, which kids can often do, turn off one eye. We call it suppression, but they turn off one image so that they only see with one eye. And we'll go into that in more detail. So that's hypertropia, upward turning. So let's talk about who complains of double vision and who this affects more. And I have these little images down here, and typically the ones who come into my office complaining, I see a lot of double vision with kids and adults, but the more patients that are complaining about it are the older ones. And that's kind of what we were just discussing. Kids can actually kind of adjust to it. They close an eye, they squint an eye, their brain is confused. And so rather than seeing double, it shuts that eye off completely. And that's the battle that us as eye doctors have to try and fix to get that eye turned back on. Because if you're not using both eyes equally, then you're not getting proper depth perception. And so if they start shutting that eye off, they're not using both eyes, they're not going to have proper depth perception and not be able to, hit baseballs or, thread a needle, things like that will be more difficult for them. Patients who have disease patients with diabetes, patients with thyroid issues, patients with strokes, their blood vessels aren't getting the proper blood supply, the proper innervation, so those muscles can kind of become lazy or start to turn. And so often we can see more patients with diseases have double vision too. Now, for these patients, struggling to see is a big thing for them. They often come in and they're very frustrated just because they've tried lots of different things to get the double vision to go away and they can't quite figure it out. So they have lots of glasses. Often I see 4 or 5 pair of glasses, one for distance, one for reading, one with the bifocal, one with Prism. They've struggled. They've gone to different people and they are not sure how to fix it. So it's definitely important to go to someone, an eye doctor that sees a lot of double vision. Okay, so we talked about double vision. Now we're going to talk about how I talk to the patients. And I have 5 special questions that I ask patients always when they come in. And the first one's my favorite. And I say it's my magic question because I ask the patients when they come in, if they have double vision, I say, well, what happens when you cover an eye? Now this tells me if it's a 1-eye problem or a 2-eye problem. If they cover the eye and they no longer have double vision, it went away completely, I know that this is a 2-eye problem, that there's something going on with both eyes to cause this to have the double vision. Now, if they cover one eye and they're still having the double vision, I know there's a problem with just that eye. So I call that my magic question because it often helps me kind of rule out which way I'm going. I always ask them, is this an old problem or new problem? New problems tend to be a little bit more serious or have my radar up a little bit more. And so I always ask that. I ask, is the double vision side by side horizontally, or is it up and down? Or sometimes it can actually be both. And this kind of helps me to figure out what muscles might be affected. I ask about any of their health problems. I'm asking them again about diabetes, thyroid problems, stroke, any kind of weakness in their muscles and their jaw and their temples, all of those things to get a really good idea of where their health has been. I ask about if this double vision is happening more far away, if it's happening more up close, or both. It can sometimes affect both too, but that actually helps me too to determine which muscles are being affected and how I can treat them. So those are my 5 questions I ask every patient. And now we're going to kind of talk about one eye double vision. We talked about that a little bit. So after I ask my magic question, and let's say they say, yes, I cover an eye and I'm still seeing double. Well, these are the main causes of one eye double vision. And the first one is that the glasses are not correct. So they've got an incorrect prescription, say they went to the optical, something was, messed up and it's causing a blurry image. It's the wrong prescription. This is an easy thing for us to fix. It's, we just change the glasses, we get it fixed up, and then they're not seeing double anymore. So that actually happens not very often, but it certainly can cause some double vision. The second one is cataracts. So this is a picture of someone's eye, and right here is the lens of the eye, and this is a pretty good sized cataract. So as you can imagine, as they're trying to look out of this eye, there's something blocking. You can think of as if I put a little piece of tape over your glasses. You're not seeing everything. So as light comes in, it's getting reflected off of that, and that can cause the vision to kind of split and you're not seeing the total image. So it can cause some double vision. So we have glasses not correct, we can have cataracts. The third thing was macular degeneration. Oh my goodness. So this is actually a patient that I just saw yesterday, and I thought I'd include it because it was very interesting. So with macular degeneration, the central vision is affected, as some of you may know. There can be swelling with fluid, there can be bleeding going on, and it can cause the vision to look double. So if we look here in my patient's eye, the left eye, we like to see this nice, even flow, and then it kind of dips down and it comes back up like a little valley here. That was the left eye. This patient was having double vision in the right eye, and you can see why. There was some bleeding going on. They had wet macular degeneration, and it was causing their macula to have some fluid here. So as this patient was trying to look out through their macula, they were having issues with color vision. It was blurry, and they were having some double vision. So this is definitely a cause of one eye double vision. This eye was not affected. The last one of one eye double vision is one of the most common ones we see, and it's dry eye. And if you look up here at this picture of this lady's eye, it's definitely looking dry. And I know that sounds weird because it kind of looks like watery. Well, sometimes when patients have dry eye, the brain sends signals to bring water. Well, it's actually kind of like you're crying tears. So this patient's eye is super dry. She needs to be using treatments to help with that. When it's not a smooth surface, that can cause it to kind of look patchy. I often tell patients, think of like you fell and scraped up your knee. The surface of it isn't smooth. And it's the same thing with dry eye. The surface is not completely smooth. You're getting dry, patchy areas, and that can cause double vision. This can also lead to it feeling sore, and it can cause it to be inflamed as well. So how do we treat dry eye? Very, very common question. And if you can see all these drops, I'm sure we've all been there. We go to the pharmacy, someone told us to get eye drops. We look at it and there's just, hundreds of them, and it's very confusing on which ones to get. I would say a lot of the drops are made up of similar consistency of products. Right here, I typically reach for Refresh or Sustain, but we want to stay clear of like the Clear Eyes or Visine. Those are just getting the red out. They're not actually providing any moisture to the eye. So your eye doctor can definitely make a recommendation of the eye drops that they feel would be best for you. But certainly if your eyes are dry, we want to be adding tears several times a day. Oftentimes we'll also add warm compresses that allows the oil from the eyelids to kind of be released and allow that oily layer back to the tears. I will often give my patients fish oil as well, again, to bring back that oily layer and keep the eyes from drying out. There's several prescription dry eye treatments that we have too that are available for patients with very severe dry eye. So we had 4 different causes of one-eye double vision, and we went through those. We had the glasses, we had the cataracts, macular degeneration, and dry eye. So those were kind of the easy ones. You know, when doctors hear that, it's kind of easy. Now we're going to go into 2-eye double vision. And this takes a little bit more thinking and a little bit more listening from the doctor to kind of figure out. So I like to kind of categorize it into 4 different categories. We've got the acute people, which mean it just happened. We've got the intermittent ones where it happens off and on, like we talked about earlier. We've got the constant ones where it's just there, it's not getting better, it's just driving them nuts. And then we've got the long-standing ones, meaning it's happened since they were younger and it's always been there. So let's kind of go through the acute and intermittent first. So patients who come in and they are complaining of double vision that has happened in the last few weeks or the last month, these tend to be a little bit more serious, and that we've got to figure out if this is something new. There's such thing that we'll talk about in a little bit about an orbital blowout fracture. If someone's been hit in the eye and the muscle has been broken, oftentimes I need to order a CT or an MRI to figure out if the muscles are being trapped, causing the double vision. If I find that there's no other muscles affected, there's just one muscle affected, they're not having any issues with their pupil or not having any other neurosymptoms, often this can be related to a microvascular disease such as diabetes or high blood pressure. These patients I tend to watch pretty closely to make sure that nothing else develops. But oftentimes with these, it is just that. It just happens because of their diabetes, and then it will get better in around 2 to 3 months. Well, let's say they're not diabetic or they don't have high blood pressure. Then I'm often going to be ordering an MRI if it's sudden onset double vision with other things going on and no diabetes, no other medical causes of it. So then let's talk about the intermittent ones. These are the patients that happen, it just happens randomly. And this is a fancy word, decompensated phoria. I know that sounds weird, but it basically is just a misalignment of the eye muscles or a tiring or weakening of the muscles. And it's something they may have had their whole life and not really understood, but it's something that an eye doctor can look at them and say what's going on and how we can fix them. And it's not happening all the time. The second thing is myasthenia gravis, and this is a systemic thing which can cause muscle weakening, and it can cause a droopy eyelid, it can cause problems with eye muscles, and certainly can cause double vision. Giant cell arteritis, this is a very serious thing that eye doctors look for, and it can often cause muscle palsies, and so we're looking for that, but it will sometimes cause the intermittent double vision as the muscles are swelling. Same thing with papilledema. This is actually an optic nerve swelling in the back of the eye, and it can cause the double vision to kind of go off and on as that swelling kind of gets worse. Again, the thyroid problem we talked about earlier, and a pseudotumor and actual tumor can cause double vision, and we certainly are on the lookout for that. Okay, so we talked about acute and intermittent. Let's talk about constant and long-standing. So again, we're still talking about 2-eye double vision. So the thyroid problems can cause that eye to completely turn out and stay that way. When thyroids, often their muscles can bulge and their eyes actually look like they're bulging out at you when their thyroid is really high, and that can cause the muscles to kind of get stuck and they can't move, and you'll see double. Tumors is obviously the very scary one that we're constantly watching out for, and why we're ordering the CTs and the MRIs, and that can definitely interfere with the eye movement and cause double vision. And then we'll have cranial nerve palsies, which we'll talk about in a minute, but that's certainly, you know, different weaknesses from diabetes and blood pressure can cause those muscles to not work quite as properly. So the long-standing ones, trauma, and that can happen, you know, anytime in life, but if there's been damage to that muscle, it's been cut, it's been severed, something has happened, it's not going to work properly, and you're not going to get that muscle to go where it needs to go. Congenital strabismus and muscle turns, we're going to be talking about those. I showed you pictures a little bit earlier about that, but that will cause long-standing double vision. Okay, so let's talk about these palsies. So I kind of split it into vertical problems and horizontal. So up and down and side to side. So let's just briefly go through those. I love this picture. He is very interesting right here, don't you think? But this is a patient who has that superior oblique palsy, and this is something, like I said, that I see very often. If you look at this center picture, I know I've got a lot going on this slide, but this is where I can see that this muscle is slightly up. This one is, can you tell? This one's up slightly. So his eyes are not aligned straight. One is slightly up, his right eye. So as he is turning his muscles, it goes up even more because that muscle is not getting the proper innervation to go down. And when he goes to tilt this way, so if he goes to tilt toward the right, it actually makes it worse. It makes the eye shoot up even more. So he's having more double vision when he goes to the right. And when he tilts to the left, it actually makes him even out even a little bit more. So often superior oblique palsy patients will come in like this, and they'll have a head tilt, and they won't even notice it. And they'll literally straighten their head out, and then they'll go double. So they kind of fix the problem by tilting the muscle where it needs to go. So they often complain of neck strain, muscle fatigue, things like that. But certainly is something I watch and see a lot. All right, the next muscle palsy is an inferior oblique palsy. And this is, again, one that kind of causes problems. It's straight ahead, they're fine, but they're not able to lift the eye up. So right here, it's the right eye. As she's trying to look up and over here, that muscle cannot go up. So she's gonna have double vision. These ones are interesting because they actually tilt to the right to fix it. So right here, she can kind of get her eyes to even out if she tilts to the same way, the right side where that muscle is affected. So I talked about this a little bit earlier, but this is called an orbital blowout fracture. And if you see this ball hitting the eye, this is the orbital bone right here. And often if there's that blunt trauma to the eye, it'll cause this bone to break. And these muscles, especially these inferior obliques and inferior rectus, they get stuck in here. And then the child, or in this case, the child could not look up because this muscle was broken. So these are definitely patients I'm going to be doing CT scans on to check to make sure if they're having the double vision and making sure that they can get better. Okay, so those were our vertical. Let's talk about horizontal now. So this is one, that was that big lateral rectus muscle I showed you earlier. And these are often, you know, we see these quite a bit. So what's happening is right here, this child, if you look here, as he's looking to the left, can you tell that this left eye is not going all the way out? There's white space right here. As he looks over here, he's able to get all the way out. But on this side, it's like that muscle is stuck. So they end up tilting their chin towards the muscle that's being affected so that they can see clearly. They're not seeing double. Because as he's trying to look to the left, he's seeing two different images because this eye can't move out. It's stuck. What causes that? Well, it can often be with older patients. We see it often with diabetes and high blood pressure patients because they just aren't getting the right innervation there. So these often get better on their own. And a kid that has no other signs, I will often image these kids too to make sure that there's nothing pushing right here causing that muscle to not go out. And these, very important, these often affect the distance muscles more than the near. Because if you can imagine, as they're looking far away, it's affected as they kind of converge or bring their eyes in. it's not really as affected as much. So this is more of a distance problem. Medial rectus, this is pretty rare. We don't see this very often, but this is affecting her left eye. So she's trying to look to the right. This muscle, this right eye, is not able to go medially or look towards her nose. The right one's doing just fine, but this left one cannot. As she's looking this way to the left, it can. So the lateral rectus muscle is fine. The medial rectus is not able to do that. All right, so let's talk about congenital muscle syndromes. And these are things that, they've had since they were little. They come in and, the pediatrician says, their muscles aren't working, they can't get it out, well, it could just be that they have this muscle syndrome and it's no other big problem. So I'll go through these pretty quickly, but this little guy, so they're very easy to diagnose for us as they're looking this way. His left eye is not able to look out. And at the exact same time, this muscle can't look out, this right eye, the eyelid actually contracts, or the eyelid kind of shuts or squeezes shut. So, in a lateral rectus palsy, it's just they can't move it out, but they don't have this other fun sign that we see. So that is called Duanes Syndrome, and we'll see that retraction of the globe and the kind of squinting of the other eye. This is Brown syndrome, and it's, again, affecting that superior oblique tendon that we talked about, and it gets stuck in there. So the patients aren't able to look up. So that muscle right here is stuck, and you can't get that eye to look up. I actually just had a patient just the other day who had this, and then as they got older, the muscle finally released, and then she was able to finally look up. So that doesn't happen very often, but it was kind of cool to see that finally, after she was 11 or 12, that muscle and that was stuck in this tendon kind of released, and then she was able to look up. So that's Brown syndrome. Double elevator palsy. This is a difficult one because they can't look up. Both the muscle, the superior rectus and the inferior oblique, both muscles that help you to look up, are not working. And so these patients often walk around like this just to kind of try and see up a little bit further because their muscles won't do that. All right, so those were the horizontals. So after I kind of get all my history and I figure out what muscles, this is where I'm going to do my actual diagnosis. I want to show you a video. This is where I'm doing what we call extraocular motilities, where I'm kind of seeing what their muscles are doing. So if you follow right here, he's just going to be following my pen, and I'm looking closely at his eyes to see if they're moving all the way out. And I go to the left, I go to the right. And then I have him look up and down. And I'm looking at all the muscles. So that's called extraocular motilities. And then I do a cover test, which is where I'm looking at how their eyes are moving. So I want you to pay attention. Look right here at this eye. Did you see it move out? It's going to do it again. And that one moved out. So they're not supposed to move when I do that, but his were, because his eye is actually turning in a little bit, and we'll talk about that. I then do a red lens test, which basically helps me to determine what amount of Prism they need, and we'll talk about that. And I do a Parks 3 step, which helps me to figure out what their muscle is and what affected. All right, so let's talk about some treatment. How do we fix these patients now? We know they have double vision. How do we fix it? So we can first use glasses. Oftentimes like myself and my daughter, by putting glasses on these patients, that actually helps their brain figure out that they can see better, and then they're able to use that muscle, and it helps them to see, and then they stay straight. We can induce what we call suppression, or turning off that eye, and we'll go through that. We can use special prisms on their glasses to help their eye to kind of see better or get to where their image is. We can do a complete occlusion, or we can do muscle surgery. And I'm going to go through all of those here. So these are my kiddos, 2 of them. I have 4 children, but these are my 2 youngest ones. And this is Ray. And when she puts her glasses on, it allows her eyes to stay straight. Now, when, she does not have her glasses on, like at the pool, her eye will turn in. But when she's got her glasses on, it stays very much straight. And then this is Logan, and we'll talk about him in a minute. So I talked about suppressing, and this is often what kids are doing just to turn that eye off. But sometimes even in adults, we have to turn that eye off because if they're seeing two images, their brain gets confused and they can't handle it. So we have special filters we can put on the glasses, special foils, sometimes even just putting Scotch tape on one eye to kind of keep that eye from seeing. And so they're only getting one image is a good treatment in itself. And then I have been using atropine a couple times as well. And this is actually a dilation drop. So it dilates the pupil, but it causes it to be blurry. So it blurs out the bad eye so that they can concentrate on that good eye and they're not seeing double. Older patients don't really like this as much. We usually use it in younger patients because of the photosensitivity, the headaches, and just seeing one pupil bigger than the other, they don't like it. All right, and Prism. So I started talking about that, but this is, I do a lot of Prism actually. And if you can look at these glasses down here, can you see right here, there's some ridges on the lenses. This is called a Fresnel prism. And what the prism is doing is if the eye is out, it basically takes the image of what they're seeing to where the eye is. So it's kind of like just a help or a crutch to help them to not have to see double. And these are so amazing. They work so well. We put them on, we actually stick a little bit of water and it's like it glues it onto the lenses. We can take it off if we need to. We can put a stronger one on. It's pretty inexpensive way to fix and help the patients. The only thing that sometimes causes some problems with patients is they notice these little bit of light scattering. They'll see it just looks a little bit more dim in that eye because of the special grooves that are with the prisms. So these are prisms. I do lots of those. They can either be like this, the sticker ones, or we can actually grind them into lenses and you don't even know they're there. They're just in the lens itself. Another treatment is complete occlusion. And these are my two again. We actually had to patch their eyes because they had one eye that wasn't seen as well. So we put patches on them. You can see one of our children was happier to wear one than the other. But they wore patches for a long time. But, and adults even, sometimes just getting this pirate patch you can buy at CVS or any drugstore and closing one eye off is helpful so that they're not seeing that second image. So that is also a treatment. And then this is my Logan. So we talked about his strabismus, or he had an eye muscle turn. Well, even with his glasses on, his eye was still turning. So we ended up having to do surgery. And we actually just did that about a month ago. And so if you can see right here, he had muscle surgery on 4 of his eye muscles. His medial rectus, because his eye was turning in, we recessed this muscle, or we allowed it kind of to shorten so it didn't turn in so much. And then one of his muscles was overacting when he was looking up too. So we did muscle surgery there on both eyes. So he did great. He's quite the champ actually. And it was great. I knew kind of what was going on. So he did great. So let's talk about, I've got some time here for some cases. I just wanted to go through those. So we're going to start with that. So my first case is an 82-year-old female, and she presented to clinic, and she was having double vision when she was looking at her Amsler grid. So I'm not sure if any of you have these at home that your eye doctors give you, but it's a great way for us to kind of follow macular degeneration patients and see if there's been any change. Well, she was looking at it and was seeing 2 of them. She was noticing it more at near than at distance, and it was with the left eye. So when I asked her my magic question, is this 1 eye or 2 eyes? It was 1 eye, and it was both horizontal, side by side, and up and down. Just started about 4 to 6 months ago. So when I did her history, we found that she had some cataracts, she had some macular degeneration changes, and she also had glaucoma. This was her medical history, no diabetes, no blood pressure. Again, she has the macular degeneration and the glaucoma. She was taking a glaucoma drop. No other symptoms that I was concerned about as far as giant cell arteritis or myasthenia gravis. Everything was normal. Her vision was not very similar, actually. Her left eye was a little bit more blurry. And as I did my exam, I saw that she had a really large cataract in her left eye, the one that she was complaining of. So she was not having any kind of neurological problems. It was simply that this cataract, when it was light was coming through, was getting scattered here and causing the double vision. So we are not going to get glasses for her. We are actually going to have her get cataract surgery, and that will help her to see. And she and I will continue to follow her dry macular degeneration and her glaucoma. So that was case 1. Let's go to case 2. And this is a 39-year-old Hispanic female, and she came in with double vision, and it was worse at distance. Now, she was one that had an eye muscle turn since she was little. She actually had trauma. She was in a car accident, and it damaged her right eye, and it caused it to go in. So she had had 2 surgeries, strabismus surgeries, just like my Logan. One at age 4, and then she had just had one when she was 38. Now, when I did my exam, she definitely has some glasses prescription, and I decided to give her some Prism because the muscle was still turning and I was trying to get her to be straight. Well, I put the Prism on her glasses and I had her come back in 4 to 6 weeks. When she came back, she's a nurse and she does tons of reading and tons of up close work. Well, she was struggling. She said she was still, just her eyes weren't working together. And it's because she's had this since she was a child and she's used to just turning that eye off. So when I actually brought the image in to kind of help both eyes, it was difficult for her. She was so used to turning that eye off that when she was seeing it, she's actually having more double vision. So what did we do? We actually decided to give her contacts, and I told her she could wear a patch over the eye if she was struggling. But she really just decided that she didn't want to use that eye and that just looking out of one eye only was the best for her. So, because that's what she's been used to as a child. Okay, so let's see. We still have a little bit more time. Case 3, this is a double vision patient and it's only when looking to the left. So it happened more at distance and it had just happened a few weeks ago and it was mainly after shoulder surgery. So this was acute or just, recently. So that's when my radar goes up and I start, definitely watching and paying attention. So this patient happened to have diabetes and high blood pressure. He had binocular double vision and it was worse when he was looking to the left. And I definitely saw, and interesting enough, this is the patient I showed you earlier. So let's review and see how much you learned. So as he was looking to the left, this muscle right here, he can't get it all the way out. And this was actually a few weeks after. It was even worse the first time he came in, but it wouldn't go out. And so something was affecting, the diabetes or blood pressure was affecting this muscle, not allowing that eye to go out. And it also caused this ESOtropia here, where the muscle was in slightly. So given that he has high blood pressure and diabetes, I did not think we needed to order an MRI or a CT scan. I believe this is related to his blood pressure and diabetes, and I'm following him pretty closely, and it actually is almost completely better. So he's doing much, much better. So I just put Prism on his glasses. I did the Fresnel Prism like I showed you earlier on the glasses, and he did amazing with that. He loved it. And then, as it got better, we were able to pull the Prism off and kind of lower it until the double vision went away. So, yeah, everything else is there. Last case. And this was a patient, 49-year-old male, came in complaining of double vision for the last several months that was getting worse. He had double vision at far away and up close, and it was both eyes. And it was better when he closed an eye. Again, double vision with both eyes. He did have a blood disorder and he had high blood pressure, and he came in with a mild right head tilt. So he kind of tilted his head to the right. So I asked him all my questions. I didn't get very much. His vision was the same. When I did my exam, it was definitely worse when he was looking to the right. He had one eye that was going up in the left eye, and it got worse when he tilted his head to the left. So do you guys remember what we talked about? A left superior oblique palsy. So left hypertropia, worse than right gaze, and worse on left head tilt. So I pulled out, I said, let's look at your driver's license. Let's see, have you had this all the time or is this something new? Well, I pulled it out, I couldn't really tell. When I can't really tell, I order an MRI just to make sure that everything was okay, and it was. He was totally fine. He'd had this since he was younger. It was just starting to get worse. We gave him some Prism in the left eye and his glasses, and he was so happy. He could read and he could see singly and didn't have double vision. Okay, so these are my 4 kids. They're great. These 2 with the glasses and these 2, the ornery ones. But anyway, so that is kind of to the end. I will definitely stay for questions. So if you guys have any questions, let me know. So it looks like we have one question here. I've been told that I have cataracts and I'm noticing double vision. Is this because of the cataracts? Once I have them removed, will the double vision go away? Now this all depends on if it's monocular or binocular. So if you cover an eye and you still have double vision, that's probably the cataract. And it will go away after the cataract surgery. Now, if you have both eyes, then obviously it's a different thing that we would have to look at. Okay. Who should I call first if I have double vision? My primary care doctor or my eye doctor? And I love this question because just because a lot of times we get referrals from primary care doctors, and if it's your eyes, if it's affecting your eyes, you should definitely call your eye doctor first. They will know how to help you. They will contact your primary care doctor. So the answer is call your eye doctor. If I fell the other day and I'm noticing double vision, should I go to my doctor or eye doctor? Okay, so this is similar. Again, double vision, if you're having anything with your eyes, go to your eye doctor. How long does double vision related to diabetes or high blood pressure usually take to resolve? Typically, it's 2 to 3 months that we see that that occur, and then after that, the blood flow comes back and the double vision improves. Okay, I have very dry eyes and I am noticing double vision now. I use eye drops and they don't seem to be helping. What can I do? If you're just using the drops, we talked about kind of in the program that there's different hot compresses you can use. There's different fish oils and prescription eye drops that you can do. I would definitely see your eye doctor to determine if the dryness is getting better or if it's not. Okay, is there a special eye doctor that I should be seeing for my double vision? You know, I would say that yes, someone who sees double vision a lot is definitely the one to see. You know, patients who are being treated for strabismus, often pediatric doctors deal with double vision quite a bit, and they are very familiar with double vision. So when calling to schedule your appointment, I would make sure that they have seen double vision patients previously. All right, what is the recovery time for strabismus surgery, and how is the surgery different for adults compared to children? So having just gone through this with my son, the recovery time for strabismus surgery is about, I'd say 1 to 2 weeks. The first week, they're very sore, they're very light sensitive. There's eye drops that we're putting in and ointment. And so they want to lay around, they want to watch movies, they want to be in the dark. That's the first couple days. But they cannot be in the pool for at least 2 weeks after the surgery. But that's really the only limitation. How's the surgery different for adults? Adults tend to not do as well as the children. It's just kids adapt so well and they're busy, and you know, adults just take a little bit longer. So certainly allow them for that. Okay, two more. I have ocular migraines, and after having the migraine, I have double vision that lasts for 3 to 4 hours. Why does that happen? Oh, that's a great question. So ocular migraines can cause the vision to blur. And oftentimes when the muscles are affected, it can cause the vision to kind of blur out, and the muscles, it's almost like they have a weakness. Lots of times patients will kind of get a numbness to one of their arms, or kind of have some issues with the migraine in general. And some patients have the double vision. So it happens because you're just not getting the proper blood flow at that point. I would say if that continues to happen, definitely contact your eye doctor and your primary care doctor. Okay, when should children have their eyes checked? Great question. So I would always say, if you have any concerns that their eye muscle is turning or moving or not looking the right way, definitely have them checked. We see babies, we see, teeny tiny babies. Usually by 3, I would like all kids checked, and I, want to see them and make sure their eyes are okay if you have no concerns. But if the eye is definitely turning or moving, you want to see them before then. All right. Thank you. I think we got them all.
Thank you. Thank you. Okay, now our next speaker, Megan Blumker, has been on most of our programs, and she represents a company called Notal Vision, of which she serves as its Director of Clinical Affairs and Professional Relations. Notal Vision makes a product that she's going to describe that is like a Amsler grid on steroids. It is much more effective at diagnosing the progression of your macular degeneration. So Megan will give you the background on how it works. And without further ado, I'd like to introduce Megan Blumker.
Thank you so much for the introduction. Notal Vision is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered. It's prescribed by your eye care professional when you have the appropriate level of vision and appropriate stage of age-related macular degeneration. It's a form of personalized medicine with the 4C Home device used at home in between your regular eye exams, and it detects metamorphopsia or visual distortions in AMD. AMD is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it doesn't resolve or go away, progressive, meaning it tends to worsen over time, type of condition. And there are 2 types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing the wet form of AMD. And wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen, or deposits, these yellow spots that you see here on the right side of the screen in the picture, build up in this area. And these changes may induce blurry vision, such as difficulty seeing sharp details both up close and far away. Dry AMD is the slow form of the disease, with changes you may not notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these drusen or deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any kind of advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula, as you'll see here on the right side of the screen. These blood vessels can leak fluid, and they can sometimes bleed without any type of warning. You may not notice these changes until significant vision loss has occurred. If you convert to wet AMD, this significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines look wavy. You can have dark spots in your vision, or just generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and before vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that's already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are even noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear in your vision, then the vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision, your independence, and the ability to go about your daily life participating in activities you enjoy. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. The test takes just a few minutes per eye per day. The data from each test is then sent to your eye doctor as well as the Notal Vision Diagnostic Clinic, the medical provider of 4C Home. If a change in test scores is detected, the diagnostic clinic alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The AMSLR grid, as you see here on the left side of the screen, was developed in the 1940s and has for a long time been recommended as a simple and accessible tool that you can use from home to monitor the changes in your vision. However, by the time you notice vision distortions on this AMSLR grid, significant vision loss may have already occurred. Fortunately, new technology such as the 4C Home AMD monitoring program has been developed so you can detect tiny changes before symptoms are noticed, and the system reports them to your doctor so you can receive immediate examination and treatment if necessary. Testing with 4C Home is easy. You turn the device on and look into the viewfinder to begin testing. Then a bump will briefly appear and disappear, as you can see here in the center green circle on the screen. You'll use the mouse provided to click where the bump appeared and then return to this center dot. Data from each test is then sent to the Notal Vision Diagnostic Clinic for evaluation and provided to your eye doctor as well. Regular at-home monitoring is like brushing your teeth. It's just a good, healthy habit you do every day to help preserve your vision. 4C Home allows you to take a proactive approach to protect your vision. A clinical partner will be with you every step of the way. After the Notal Vision Diagnostic Clinic receives a referral from your doctor, we'll answer any questions, verify coverage, and ship your device. Once you receive the device, the Notal Vision Diagnostic Clinic will walk you through setup and training. You and your doctor will continue to receive feedback from the Notal Vision Diagnostic Clinic. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and prior to getting started with the program. There are low out-of-pocket costs for Medicare patients. So patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay $15.06 per month once their yearly Medicare fee-for-service Part B deductible is met. Again, 4C Home is FDA cleared and Medicare covered. Your doctor will send our Notal Vision Diagnostic Clinic the order for you to begin the 4C Home AMD monitoring program. And appropriate candidates have a particular stage of dry AMD and a particular level of vision, which will be determined by your doctor. You'll continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for an examination. In summary, The Notal Vision Diagnostic Clinic works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. I'm happy to answer any questions you might have, and thank you so much. Here's my contact information for your reference. I would love to hear from you. The first question is, I have Parkinson's and my hands shake and sometimes I freeze. Can I use this machine? So when using 4C Home, the only physical requirement besides placing your forehead against the little viewer is using a mouse, that kind of like a mouse you would use with a desktop computer, or you'd rest your hand on that and you would click on the button when you see the stimulus or you see the line with the bump or the wave on the screen. And so when you're taking the test, you would have ample time to go from that center dot to where you saw the bump and back. Now, if you find that once you have started using 4C Home or you're giving it a try at home and it's just not working for you, the good news is there's no obligation to stick with our program. We will happily send you shipping information and pay for that to get the device back to us. But we have a lot of patients who have found that because it is just a slight movement and because they can take as much time as they need to do the test, that they've been successful with that. But like I said, if it didn't happen to work out for you, then we would happily take back the device at no cost. We'd make sure that was fixed for you. The next question is, my vision is blurry and I have trouble with near vision. Can I use this program? So your doctor would need to prescribe or send us the referral for you to get started with the 4C Home AMD monitoring program. And at that point in time with that referral, they'll determine what stage of dry age-related macular degeneration you have. It needs to be at that intermediate or middle stage. And they would also determine your best corrected level of vision. So your distance vision or driving vision. And if it is at a certain level, usually around 20/60 is what is actually required. Most driving is around 20/40. So the smaller the number, the better the vision. So if you have good correctable distance vision that your doctor would determine, then you should be able to do this. The way the test is designed with the optics of it is that if you have your glasses on or if you're correctable to see far away, then you should be able to use the device no problem. But again, your doctor would determine that level before the referral would come to us. The next question is, my doctor handed me an AMSR grid. Why didn't he suggest this program? I think Larry had a great description in the introduction. Thank you for that, Larry. It's like an AMSR grid on steroids. I think that because, as I'd shown in one of my slides, that AMSR grid has been around for such a long time, and it is the current standard of care, that when you have newer, better technologies like this or options that come out, it takes us a little time, especially as a small company, to get the word out. So I would love for you to take this information that you have learned today back to your eye doctor and share with them that you would like to learn more about it, see if you're a good candidate for it. You can also go to our website, which is 4chome.com, or you can go to the Macular Degeneration Association website, which is the macularhope.org website. But we'd love for you to help us spread the good word about this great option that's available. Next question is, how do I get this machine? Again, I would say go back to your eye doctor, have to be at that certain level of vision, certain stage of AMD, and they would be able to best determine if you would be a good candidate. If you don't have an eye doctor that you're seeing regularly, then we do have a physician locator on our website, so you can see who has access to this technology in their practice or who has worked with us. The next one says, my friend told me about this as it saved her vision. That is awesome. Which doctor should I see in order to get this program? Well, congratulations to your friend. I'm so happy to hear instances such as this where someone you care about or someone that you know has had great success with 4C Home doing exactly what it was designed to do, which is detect that conversion from the dry to the wet kind of AMD earlier. So thank you so much for sharing that. That just really pleases me and reiterates that this is why we do what we do. We love caring for our patients and helping preserve vision. As far as which doctor to see to get the program, any licensed eye care provider, so an optometrist or an ophthalmologist, can determine if you're a good candidate and refer you for the program. The next question is, I was told that this program would not be good for me as I have low vision. Why is that? This is an excellent point that you bring up. Because of the level of vision that's required to be able to perform the test. So being able to see at that 20/60, that level of vision or better, the way that the device is designed, the way that the artificial intelligence or the algorithm presents those lines with the bumps, you have to have a certain level of clarity when you have your near vision. So unfortunately, if you are not able to see at that level, then you would not probably have an easy time being able to use the technology, and it would not be able to work as it was designed to. So it might give you a false sense of security with using the device. So unfortunately, you would be beyond that point, but I know that there are lots of resources available for low vision aids. There are optometrist colleagues of mine who specialize in this area. So be sure to reach out to the Macular Degeneration Association. I'm certain they have references for you as far as best ways to go about getting help. Once you're beyond the point of 4C home, there's still a lot of great things that are available that we eye care professionals can do to help you and just support you in your daily life. So great questions today. Is there anything you'd like to add, Larry?
Well, you're so upbeat.
Oh, well, thank you. I have a lot to be grateful for, and I hope it comes across that I love what I do, and I love working with you all. I love caring for patients, so I'm always happy to share this great news and great technology.
Yeah, well, I'm a living example of what can do. And I just urge everybody to really pay attention. Macular degeneration is an epidemic in this country, if it isn't around the world. And we're talking about more than 11 million people. You have to take care of yourself. This device is very important. So all that being said, I want to remind everybody to please take the survey. Please go to macularhope.org for future programs. We have numerous ones coming up throughout the year, and we'd like to invite you back to participate. And thank you very much. Thank you, Dr. Blumker, and
Thank you.
everybody who joined us. Have a good day.